Welcome to part 2 of PET-CT head to toe. No conflict of interest on this talk. Let's start with a couple cases. You're reading a PET-CT and you see this, or this. We'll be discussing these cases and more during this talk. First, let's deal with the chest. Myocardial activity is variable on an oncologic PET scan. The patients effectively fast anywhere from 4 to 18 hours, depending on when the study is scheduled. Now, activity decreases with fasting as the cardiac muscle shifts to fatty acid sources of energy. In the fed state, glucose metabolism prevails. In fact, this is why we feed the patient and give them insulin for a cardiac viability PET. Now, activity can be non-uniform. Typically, the base of the left ventricle is the last to lose uptake. Atrial activity can be variable and may appear focal. And right ventricle has low-level uptake, but it could be intense with right ventricular hypertrophy. This is the spectrum of normal left ventricular activity, from minimal activity to higher activity. This patient has cardiac disease, and we see what looks like four-chamber uptake, very similar to an echocardiogram. Notice that this patient has discontiguous activity in the apex with apparent photopenia. This turned out to be an apical mural thrombus on echocardiogram with an aneurysm in a lymphoma patient. Again, looking for that discontinuity is important. Another patient with a discontinuity in the lateral wall. And this patient was post-MI and had a hypokinetic infralateral LV wall consistent with scar. Now, the mediastinum and the great vessels may also show FDG activity. Since uptake is dependent on FDG incorporation into organs and tissues of the body, poor uptake due to hyperglycemia or other factors such as steroids will result in higher blood pool activity, and there could be an angiographic type effect. Focal activity can sometimes be seen with atheromatous disease in vessels, and in fact, this is an area of research looking for unstable plaque. So here we could see just a slight angiographic effect from increased blood pool for FDG. Now, as far as muscle, at rest, fatty acid metabolism prevails, but with activity, there's increased oxygen demand and tissue oxidative capacity, so more glucose is needed. Now, activity during the uptake phase, or strenuous activity the day before, will result in replenishing of the glycogen stores, so if the patient then has a PET, you'll have increased muscular activity. Both insulin and increased glucose increase muscle uptake as well, and uptake can be focal at the origin and insertion of muscle. Here we see normal paravertebral muscle uptake, commonly seen, especially if a patient is shivering. This patient looks like maybe they were working out the morning of the exam, and we could see activity in the shoulder girdle as well as within the muscles of the lower body. This patient has focal paravertebral muscle uptake. Most of the time this is a normal variant, but if you see intense uptake corresponding to a soft tissue nodule, sometimes one can have muscle metastasis in melanoma or lung, for example. Now, this patient was coughing throughout the uptake phase, and this looks like a Frank Netter diagram of the diaphragmatic muscles. Crural uptake is commonly seen and best appreciated on the coronal views. Breast activity is more commonly seen in younger women with denser breasts and in lactating women. We'll also discuss these other situations. So here we see in a younger woman with denser breasts, there is typically low-level diffuse uptake. In older women with more fatty breasts, there is less uptake. This patient was lactating, and there is a diffuse activity in both breasts. And in fact, we give the patient special instructions when they are lactating, even though the FDG does not get into breast milk in any appreciable quantity. We do not want the patient to hold their infant up to their breast so soon after getting a scan. So we have a kind of a graduated exposure over 12 hours. And we also tell the patients to pump before the scan. This is a patient with implants, and we could see kind of a Mickey Mouse appearance where we have a mild diffuse activity around the implants, commonly seen as well. It's also common to see periareolar uptake. That is just a normal variant. Now, as far as the thymus, thymic activity is common before puberty. We have seen it well in the 50s, especially in patients who are post-chemotherapy who get thymic hyperplasia. It's also been reported in Graves' disease. And the delta triangular configuration that we have seen from gallium scans is common. There's also decreased thymic uptake during chemotherapy. This is a 10-year-old girl with lymphoma who had recent chemotherapy, and this is just normal appearance of the thymus. There's a 35-year-old who is status post-chemotherapy for stomach malt, and we could see a little thymic hyperplasia, and this was stable over 6 months, had nothing to do with the lymphoma. Now, this is an interesting case of a baseline appearance of thymus in a young person. There's also a little brown fat. During chemotherapy, we could see the thymus shrinking, both on the CT and with decreased activity on the PET. Now, the thymus extends into the superior mediastinum above the brachiocephalic vein. If we look at axials alone, it could appear as an isolated focus of abnormality. So we want to look at the MIP and the coronals for the overall view, and keep in mind that that activity should have similar SUV to the main thymus. So here we have an axial images showing what looks like focal activity. But when we look at the coronal, we see that this is clearly just thymus extending above the brachiocephalic vein. Esophageal activity can typically be seen as low level throughout the esophagus. Now, esophagitis will cause more intense and fusiform uptake, and more focal uptake at the GE junction is common, as is uptake in a hiatal hernia. This patient had mild diffuse uptake through the esophagus. Can we be certain that this patient doesn't have a little reflux esophagitis? It's possible, but this type of pattern is commonly seen. On the other hand, this patient clearly has more uptake, and this was due to radiation esophagitis. Uptake at the GE junction is common at the lower esophageal sphincter as well. And uptake in a hiatal hernia, PET-CT is especially helpful in this regard. Now, ports, lines, and tubes can cause uptake, especially if they have metal, and we have that metal over-correction artifact. So in this patient who has a port, it looks like there's activity at the port, and the port was not used for injection here. But on the non-attenuation corrected images, that uptake resolved. So this is just an artifact of the attenuation correction algorithm. This is one reason why we like to inject in the patient contralateral to the side of the abnormality. So this patient had extravasation at the injection site, and we could see that there is uptake in a normal appearing lymph node as well as within a lymph channel. Knowing what unilateral hyperinflation looks like, also helps explain the PET. So your knowledge of CT will also help explain PET findings, and this should be integrated. So this patient, for example, has hyperinflation of the left lung, and it's deviating the mediastinum to the right. This is due to a squamous cell carcinoma at the hilum, which is causing a ball valve type mechanism with hyperinflation of the left lung. You may also come across other urgent or emergent findings on the PET-CT. We, in fact, like to teach our technologists to recognize some of these abnormalities so they can call us before the patient leaves the department. We also thank them when they call, even if it turns out not to be a true emergency. So this patient, for example, has multifocal pneumonia. Be nice to know about before the patient leaves. From our earlier case, here we could see pulmonary emboli detected on a PET-CT, which this patient happened to have IV contrast for as well. We could see the filling defects, and we were able to call the clinician and advise them that this was happening. In fact, the patient was still in their waiting room when we called him. Remember that pulmonary emboli are common with cancer patients. Also, from earlier, typical appearance of a large pneumothorax with some tension. We certainly want to know about this before the patient leaves the department. Here is a patient with a large pleural effusion, associated atelectatic lung, could be causing some respiratory compromise. And this is a patient who went for alternative therapy in Mexico for a breast cancer, which ended up basically eroding through the chest wall and causing a sucking chest wound, resulting in a tension hydropneumothorax. Here we have a pericardial effusion, certainly a large one, deserves a phone call to the clinician. And a pneumomediastinum, which most of the time occurs due to instrumentation. Again, definitely worth further evaluating and alerting the clinical team. This is an area that is commonly overlooked on PET-CT scans, but always be aware that there could be aneurysmal dilatation of the aortic root, and that also should be reported. This is a patient who had a contrast PET-CT. Notice that there is air in the pulmonary artery due to air in the line not noticed by the technologist when they were doing their IV contrast injection. This amount of air typically wouldn't hurt the patient, but the patient should at least be observed. Also, beware apparent ground glass. Sometimes it doesn't look very noticeable, especially on our lower dose CT scans on the PET-CT. Here we have the patient with a little geographic ground glass. And really, it didn't have much FDG uptake. Many times this could just be inflammatory, but follow-up needed, since a bronchoalveolar cell cancer or low-grade adenocarcinoma with lipidic pattern can appear exactly similar. Here we have a patient with a lung nodule with practically no FDG uptake. As a matter of fact, looking at older CT scans, the doubling time was over 1,000 days. This was carcinoid of the lung, which typically has little to no FDG uptake. Also, FDG PET may be used for infection evaluation. Now, Medicare does not reimburse for this, but as an inpatient, it's actually less expensive for us to do an FDG PET than a tagged white blood cell scan. This is a patient with a aneurysm of the aortic arch, and the clinician wanted to know if this was infected, and indeed, on FDG PET, we proved that it was. This case is sent to me by a colleague, and this is just to show that everything that has uptake on a PET is not necessarily a tumor. This is a sponge that was left in a patient, otherwise known as a gossypoma, and notice the intense FDG uptake that resulted around this foreign body. And remember that sometimes the problem may be outside your area of interest. This is a case of an elderly female who has a history of lung cancer post-left pneumonectomy, with metastasis to the right upper lobe, treated with chemotherapy, and a PET was ordered for restaging. On the older PET, we could see the metastasis. This resolved on the newer PET. But notice on the new PET that something else is up. Perhaps you're able to see that there is now uptake in the gallbladder wall. We could also see this uptake in the wall on the axial images. And indeed, this patient does have acute cholecystitis. We'll be talking more about this pattern later. And that is our segue to abdomen normal uptake and variance portion of the talk. So let's start with a couple cases. You're reading a PET-CT for lung cancer, and you see this. Or this. So we'll be talking about these cases and more in this portion of the talk. First, let's discuss misregistration. This is one of the more challenging aspects of PET, and this could occur not only in the chest, but also in the abdomen and other structures. So in this PET scan, we could see there is a CT, PET, fused image, which is fused from the attenuation-corrected PET, which is this one, and a non-attenuation-corrected PET as well. On this study, it appears that there is activity in the liver, and we could also see it on the axial images. But this activity doesn't make sense. It's spanning the gallbladder fossa. And if we look carefully, we could see that this is simply due to respiratory misregistration of colonic activity on end. We could actually see colon here. And when we look at the non-attenuation corrected images, we can nicely separate liver outline from that of colon. This is one of the reasons that we should look at non-attenuation corrected images as part of our workflow. Here we have another case of misregistration at the base of the lung. There is apparent activity in the attenuation-corrected PET at the base of lung, looking like perhaps there's a lung nodule. But when we look at our non-attenuation-corrected images, we could see that these nodules are subdiaphragmatic, as also demonstrated on the MR. So let's discuss the GI tract. GI tract activity is widely variable, and sometimes it's challenging to distinguish this from pathology. Normal GI tract activity is usually contiguous, but it could also be focal at times. But focal activity can also be seen from a polyp or cancer. Inflammatory bowel disease or other causes of colitis can also cause false positive uptake. Now, PET-CT is invaluable in this regard. And as we mentioned before, GE junction uptake is common and probably related to the lower esophageal sphincter. Stomach activity is usually mild and diffuse, more common and intense at the fundus, but it can be focal or appear focal, especially if the stomach is contracted. There can also be uptake within a hiatal hernia. My general rule of thumb is if activity is more intense distally than proximally, or it's focal and related to a CT abnormality, it should be further evaluated. This is an example of just normal stomach activity in a collapsed stomach. Small and large bowel also may have low-level activity, which is contiguous and looks like bowel, but it can be more focal, especially in the right colon. due to a combination of smooth muscle, active mucosa, lymphoid tissue, secretions, and microbial flora. Generally, focal or segmental activity that is more intense than liver and standing out from other bowels should be further evaluated. Now, though we may worry about tumor, statistically most will turn out to be benign, and CT correlation can be helpful. Again, causes of inflammation and colitis can cause increased FDG uptake in bowel. This is just an example of various degrees of small bowel and large bowel activity in this study and here as well. Here is a collapsed colon, just with normal low-level activity and a normal appearing colon. Now, this case, on the other hand, there is intense activity associated with a soft tissue nodule, and that is a colonic polyp. Metformin can cause increased uptake throughout the bowel, in both large and small bowel. And this is a characteristic appearance of metformin bowel. And many times, if you have this appearance and the bowel looks otherwise normal, and you look at the medication record in the electronic medical record, you'll see that metformin is being taken by the patient. There's just some examples of differentiation on CT between abnormal thickened bowel and Crohn's disease on the left and normal bowel on the right. Here's a small bowel obstruction due to ventral hernia. Again, can be seen occasionally on PET or PET-CT and should be further evaluated. This is a patient who has large bowel obstruction from cancer, and we could actually see the transition zone in the pelvis. The study was actually not read until the next morning. This was done as a very late case, and in fact, the patient had already gone to the emergency room for abdominal pain. Here we have another case sent to me by a colleague at another institution. This patient had persistent abdominal pain after being operated on for colon cancer, and also had a treatment for a recent urinary tract infection, or so they thought. This patient had intense activity in the right lower quadrant, and they thought this was a cancer recurrence, but the giveaway here is that there is a small density, which is an appendicolith, and this patient had appendicitis on surgery. Again, not everything that is hot is cancer. Here on CT, we see acute appendicitis versus a normal appearing appendix. Characteristic diverticulitis with inflammatory mesenteric stranding on CT. And you can imagine what this would look like on PET. This patient had a diverticular abscess, also had esophageal cancer, and which we could see on that image. But there was also uptake in the large bowel corresponding to a classic diverticular abscess. There was nothing to drain. This is probably from the chemotherapy. Recent surgery can also cause intense FDG uptake. This patient had a G2 placed 3 days before. No, there is not an infection present. This is just the normal appearance of recent surgery. Now, as far as the liver, that is a challenging area to evaluate on PET. There's normal heterogeneity, as well as that area can be prone to respiratory artifact, as we've seen in the earlier slides. Just some things on CT to be aware of. If you see it on PET, for example, this patient has pneumobilia and pneumatosis. And as we saw before, if we see uptake in the gallbladder wall, think of cholecystitis or possibly tumor, especially if the activity is focal. Occasionally, as a physiologic variant, you can see activity within the lumen of the gallbladder itself, and that has just been described as a normal variant. This is not a PET case, but this can show you how nuclear medicine can also tip you off to other anatomic abnormalities. This patient had a HIDA scan. We see the gallbladder is pointed upwards, and there's a waist to the liver. That looks very, very abnormal, and a CT scan was obtained, and this turned out to be a ruptured diaphragm from an accident years before, and you could actually have delayed symptoms from diaphragmatic rupture. Notice that the appearance on CT is exactly like on the HIDA. Normal pancreas should have little to no FDG uptake over background. But pancreatitis, as one can imagine, should have increased uptake. As in this patient, this was a gastric cancer follow-up. Patient clinically had pancreatitis, and we could see just a little bit of fluid around the pancreas, and there's diffuse activity throughout the pancreas. IgG4-related disease may also have increased FDG uptake. Now, as far as the adrenal gland, there have been many papers written about this. The general rule of thumb is no uptake or not greater than liver is considered good. Of course, you want to watch out for necrosis, which can artifactually decrease FDG uptake, or at least have the appearance of such. And you want to combine the appearance on PET with CT. Also, be aware of collision lesions, which are metastasis next to an adenoma. Make sure the studies are well registered. Intense uptake is typically malignant, but there's some benign exceptions, like pheochromocytoma. Cushing disease typically will have bilateral activity. About 3% of adenomas may have more intense activity. And a myelolipoma with hematopoietic elements can also have increased FDG uptake over liver. This is a patient with bilateral adrenal lesions. On the right, we have a low-density adenoma, which has no FDG uptake. But on the left, we see discontinuous uptake in an ugly-appearing left adrenal mass, and this was a left adrenal cancer. Here's another patient, 72-year-old male with lung cancer, kind of mild uptake in the left adrenal. And this may correspond to a low-density nodule or hyperplasia. And this was stable on CT scan 6 months later. Uptake was perhaps slightly greater than liver, but only slightly. Now, unlike glucose, FDG is not well reabsorbed by tubular cells of the kidney. So you want to make sure the patient is well hydrated to wash out renal excretion. Some centers advocate Lasix, most do not use it. Now, the patient is lying supine, so the radiotracer will pool in the upper collecting system because that's more posterior. You also want to look for diverticula, communicating cysts, redundant, and duplicated ureters. Remember, a simple cyst should be photopenic, should not have any uptake at all. If you see any uptake within a renal mass, this should be further evaluated. For example, this patient with esophageal cancer had incidental uptake in a solid left renal nodule, fairly intense, and this is cancer until proven otherwise. Now notice this patient with an ugly appearing renal mass on the right. The level of activity is really no greater than that of renal parenchyma. Again, any activity at all within a renal mass warrants further investigation. Now this patient had intense activity within a apparent abnormality which is in the kidney. Now, the SUV was 57. That's very high. And this patient otherwise just had low-grade lymphoma. On further evaluation, we saw this activity was related to this low density area in the kidney, so we got an MR, and this turned out to be a calyceal diverticulum. Now don't confuse a pelvic kidney with a tumor. Notice that there's a kidney on the right, but no activity from kidney on the left, and this is just a pelvic kidney. Now we've discussed brown fat in part 1 of this talk, and I noted that brown fat uptake can even be perirenal, and this is an example of brown fat activity corresponding to nice normal perirenal fat. Now, activity in the ureters is usually linear and easily identifiable, especially on the coronal images. Focal ureteral activity may look like a lymph node, but CT fusion helps in this regard. Bladder activity is usually intense, but with our modern iterative reconstruction, it doesn't obscure the pelvis as badly as filtered back projection did on the older scanners. You also want to look for diverticula, nodules, TERP defects, and it's helpful to window widely for complete bladder examination. Some advocate use of a Foley, but most centers do not use a Foley catheter. Here we have a duplicated right ureter. How do we know that? Well, when we look at the coronal images, it's very obvious. Here is a duplicated system in the right kidney. And it's common to see a little holdup of radiotracer where the ureters cross over the iliac vessels. So that is just activity within a ureter, not a lymph node. Always look for those incidental findings as well. This patient has new mild hydronephrosis. It looks like an extrarenal pelvis, but the patient did not have this on the prior comparison study. Why do they have that? Well, a couple slices down, we could see a stone in the ureter, and that can cause holdup of radiotracer due to obstruction. The bladder should be carefully examined. Here we have right UVJ stone, and also the path of the ureters. Here we have a left ureteral stone. A bladder diverticulum can fill with FDG and appear intense. Again, on our PET CT, it is obvious that that is what is happening. Emphysematous cystitis, as in this case, can also manifest with increased FDG uptake, as we see here. And this patient had a bladder tumor, and it was obscured on normal windows with FDG activity. But when you window widely, as we see here, and also examine the CT very carefully, we can see the bladder mass, and in fact there's a little peripheral activity in the mass with an SUV of 5. It's just overwhelmed by the FDG activity in the urine. Now, as far as the uterus, general rule of thumb, in premenopausal patients, there is normal endometrial uptake of FDG. It changes cyclically. It can increase during the ovulatory and menstrual phases. But if one sees uterine activity postmenopausal, this should be further evaluated. Here we see a uterus with a slightly hotter stripe at the endometrium. In premenopausal patients under hormonal control, there may be intense activity in fibroids. If there is any question, correlate with ultrasound or get an MR. If we see this pattern in a postmenopausal patient, this should be further evaluated for cancer. Here we see uptake within the vagina in a young female with a benign mediastinal mass. Examination of the CT reveals a tampon. This activity is not likely due to the menstruation itself, but probably from a collection of urine in the tampon. With ovaries, we have the same rule of thumb as the uterus. Premenopausal, it's common to see increased unilateral uptake with ovulation, and it may even be intense. Occasionally, someone can ovulate bilaterally, but this should be carefully examined for any morphologic abnormality, since one also could have cancer in those locations, especially with certain genetic mutations. You also want to look at the morphology of the ovary, as is mentioned, because this may need follow-up if it looks pretty ugly. Any postmenopausal activity, though, should be further evaluated in the adnexa. And there have been many papers demonstrating that you can have uptake within both benign and malignant lesions within the adnexa, again, in premenopausal patients. This is just an interesting example of a dermoid cyst. There's no FDG uptake, but occasionally we'll see that on a PET-CT as well. Now, this patient had gastric cancer, and they were postmenopausal. There was abnormal uptake in complex bilateral ovarian masses, and these turned out to be Krukenberg tumors, Krukenberg drop metastasis. Now, the men get equal time here. Testicular activity is normal and decreases with aging. But if you see unilateral or very intense uptake, this should be investigated further. Here we have normal, moderate testicular activity. But if you see something like this should be further investigated. In fact, this is seminoma with typical nodal spread into the mid-abdomen. Remember that CT adds other information, and there also have been many papers written about follow-up of incidentally discovered findings on CT that may not have any FDG uptake at all. So looking at our earlier images, this patient has a 6 centimeter AAA and a horseshoe kidney, just incidentally seen on the PET-CT. Nothing to do with the primary cancer, but this may cause the patient much more harm than the primary cancer. So pick up the phone. Sometimes when we give contrast, we could see things like aortic dissection. Also, free air is occasionally picked up. You should be familiar with that appearance. Now, most free air turns out to be due to instrumentation, recent surgery, etc. But patients can also perforate a bowel. Finding a pneumoperitoneum is easier when you use lung windows and other imaging planes. We could see here the air under the diaphragm, and some subtle air under the diaphragm, in this case, seen on the coronal images. Ascites typically will have little to no FDG uptake, and it would be diffuse. But remember this pattern. This patient has ascites, and there is also this nodular uptake in the omentum, and this is omental caking. And remember that not all cancer has FDG uptake. Here we have a patient with mucinous adenocarcinoma with absolutely no FDG uptake. And mucinous histology often will have no FDG uptake. So we're going to go on to a little bit of a quiz. First, this case that we saw earlier. I'll give you a few moments to look at it. Is this tumor, pulmonary emboli, FDG clumping, high density artifact, or normal? The answer is pulmonary emboli. Second question. Of the following, which lung nodule would typically have least FDG activity? Squamous cell carcinoma, carcinoid, melanoma metastasis, active TB, or small cell carcinoma? And the answer is carcinoid. Quiz question number 3. When evaluating the significance of adrenal activity, which background structure is recommended to make that comparison? Kidneys, spleen, muscle, liver, or fat? And the answer is liver. Quiz question 4. What degree of uptake should one normally see in a benign renal cyst? No uptake, not greater than renal parenchyma, not greater than muscle, not greater than liver, or equal to urinary activity? And the answer is no uptake. And for our last quiz question, ovarian uptake in a premenopausal female is of what likely etiology? Ovulatory, tumor, infection, urinary contamination, or torsion? And the answer is ovulatory. Thank you for your attention.